Pulmonary embolism is one of the most feared diagnoses in medicine because it kills silently, quickly, and often without warning. It is the third most common cause of cardiovascular death after MI and stroke. Yet with rapid recognition and risk stratification, the vast majority of patients survive. Today we walk through PE, pathophysiology, diagnosis, risk stratification, and evidence-based management from anticoagulation to thrombolysis. A pulmonary embolism occurs when a thrombus, most commonly from a deep vein thrombosis in the proximal leg, dislodges and lodges in the pulmonary arterial tree. Less commonly, emboli originate from pelvic veins, upper extremity veins, or right heart thrombi. Virchow's Triad describes the three conditions that predispose to thrombosis: venous stasis, endothelial injury, and hypercoagulability. Risk factors include prolonged immobility, recent surgery, malignancy, oral contraceptives, pregnancy, prior VTE, inherited thrombophilias like factor V Leiden, and antiphospholipid antibody syndrome. The pathophysiology has two components: mechanical obstruction and neurohumoral effects. The clot physically blocks pulmonary blood flow, causing increased pulmonary vascular resistance. The right ventricle, which operates at low pressure, is suddenly forced to pump against this high resistance. RV afterload rises, RV dilates, and eventually the interventricular septum bows leftward, reducing left ventricular preload, dropping cardiac output, causing obstructive shock in massive PE. Simultaneously, serotonin and thromboxane released from platelets cause pulmonary vasoconstriction and bronchoconstriction, worsening VQ mismatch and hypoxemia. Clinical presentation varies enormously. Classic symptoms include pleuritic chest pain, dyspnea, and hemoptysis, but this triad is present in fewer than 20% of cases. Tachycardia is the most consistent finding. Massive PE presents with hypotension, syncope, cardiac arrest. Submassive PE shows RV strain without systemic hypotension. Low-risk PE may present with only mild dyspnea or an incidental finding on CT. Diagnosis begins with clinical probability assessment. Use the Wells score. Clinical signs of DVT, 3 points. PE most likely diagnosis, 3 points. Heart rate above 100, 1.5 points. Immobilization or surgery in past 4 weeks, 1.5 points. Prior DVT, PE, 1.5 points. Hemoptysis, 1 point. Malignancy, 1 point. Score above 4 is high probability. 2 to 4, moderate. Below 2, low. In low-probability patients, a negative D-dimer, especially age-adjusted D-dimer, safely rules out PE without imaging. In high-probability patients, go directly to CT pulmonary angiography, CTPA, the gold standard. Ventilation perfusion, VQ scanning, is used when CTPA is contraindicated, such as in renal failure or pregnancy. Echocardiography is not diagnostic, but identifies RV strain, critical for risk stratification.
Risk stratification drives management. The simplified PESI score identifies low-risk PE, age below 80, no cancer, no chronic cardiopulmonary disease, heart rate below 110, systolic BP above 100, oxygen saturation above 94%. Low-risk patients can be managed as outpatients. High-risk patients require ICU-level care. Massive PE, hemodynamic instability, systolic BP below 90, cardiac arrest, requires immediate systemic thrombolysis unless contraindicated. Alteplase 100 mg IV over 2 hours is standard. Contraindications include recent surgery, hemorrhagic stroke, active bleeding. In cardiac arrest from PE, give alteplase 50 mg IV bolus and continue CPR for 60 to 90 minutes. Catheter-directed thrombolysis delivers lower-dose thrombolytics directly into the clot via pulmonary artery catheter, used in submassive PE with severe RV dysfunction when systemic thrombolysis risk is too high. Surgical embolectomy is the last resort for massive PE when thrombolysis fails or is contraindicated. Submassive PE, RV strain on echo or elevated troponin and BNP, but hemodynamically stable, is the gray zone. Anticoagulation is standard. Whether to add thrombolysis is debated. The Pytho trial showed systemic thrombolysis prevented hemodynamic decompensation but doubled major bleeding and intracranial hemorrhage risk. Most centers use catheter-directed thrombolysis selectively. Low-risk PE, anticoagulate and discharge early. DOA selection, rivaroxaban or apixaban, allows outpatient management without bridging. Apixaban 10 mg twice daily for 7 days, then 5 mg twice daily. Rivaroxaban 15 mg twice daily with food for 21 days, then 20 mg daily. Both are non-inferior to warfarin with lower bleeding risk. Duration of anticoagulation. Provoked PE from a transient reversible cause, 3 months. Unprovoked PE, at least 3 months, consider indefinite based on bleeding risk. PE with active malignancy, LMWH preferred historically, but DOAs now approved and preferred per Caravaggio and Hokusai VTE cancer trials. Long-term complication to know, chronic thromboembolic pulmonary hypertension, CTEPH, occurs in 2 to 4% of PE patients. Persistent clot organizes into the pulmonary arterial wall, causing progressive pulmonary hypertension. Treated with pulmonary endarterectomy or rivaroxaban. Screen with echocardiography at 3 months if symptoms persist. Subscribe to Medical Sciences Unfolded for daily deep dives into clinical medicine and pharmacology.